morning, everyone. I don't know if it's working. Yeah? Okay. So thank you for the introduction. I'm a neurologist here at this Pitié-Salpêtrière Hospital ALS team. So I will guide you out of the fast presentation into the C9orf72 mutation, and I will share with you our data on 36-month spinal cord MRI in a cohort of asymptomatic carriers of the mutation. So as you all know very well, C9orf72 hexanucleotide repeat expansions are the most common genetic cause of ALS and FTD. The mutation has an autosomal dominant transmission with an age-dependent and incomplete penetrance and a very large clinical spectrum with overlapping ALS, FTD syndrome, but also subjects in the same families presenting with psychiatric symptoms or non-motor neurological symptoms. Something that all the subjects have in common is that they carry the mutation and they have a very long presymptomatic phase, which can precede a prodromal phase, which has been recently described mainly from the cognitive point of view. This means that very young subjects often don't show any cognitive nor motor symptoms, and then before developing ALS or FTD, they can have a prodromal phase when they start having some abnormalities. It has been studied mainly from a cognitive point of view, but they don't meet the criteria for dementia. So what we and quite a lot of other teams have been trying to do is to study some biomarkers that could help us identify at-risk subjects for phenoconversion and possibly try to identify those who are going through the prodromal stage to the appearance of the symptoms, knowing that maybe it could be a good moment to try to treat them with upcoming treatments. So one of the cohorts that we have been studying in these years is the PrevDemals cohort, which is a multicentric C9orf72 carriers cohort, which allowed us to publish quite a lot of papers on brain pathology and brain MRI. I won't talk about that since I don't have a lot of time, but we already published a first paper on a spinal cord MRI pathology in this presymptomatic group of subjects. And at the beginning, we couldn't find any gray matter cross-sectional atrophy reduction, but we observed the presence of a white matter atrophy in the carriers of the mutation, especially those who were older than 40 years of age. And what was the most interesting at the time was that we were able to describe a progressive and significant FA reduction in the corticospinal tracts in the carriers. It means that the corticospinal tracts seems to be degenerating quite early in the history of the disease. So the actual aim of the study was to further characterize the cohort, and we added a third time point at 36 months observation time. So we had three groups of subjects, a group composed by 72 subjects coming from 46 independent families who were first-degree relatives of someone having C9orf72 related ALS or FTD. This group of subjects was tested, and 40 resulted to be carriers of the mutation, while 32 were non-mutated healthy relatives. And then we had a third group of 40 randomly selected healthy controls matched for age and sex. So the healthy control only underwent one MRI, and family members underwent a free MRI at M0, 18, and 36. This is the imaging protocol. So we always do, so a T2 cervical spinal cord MRI, it is useful to identify vertebral levels. And then we have more specific sequences like diffusion sequence to compute DTI parameters, and MEDIC or T2 star sequence, which is quite interesting because it allows us to see white matter and gray matter and to describe them in a more precise way. We use an automatic tool to segment the spinal cord, identify the vertebral level, obtain the cross-sectional area for vertebral levels, We can compute DTI for the main white matter bundles. Here we focus mainly on corticospinal tracts and dorsal columns. And then we can segment the white and the gray matter and obtain a cross-sectional area for the two separately. So we analyzed the data using linear mixed effect models to study the differences in the subgroups cross-sectionally and then longitudinally. And then over the observation time, we had some subjects, I will describe them better later, who went to a prodromal phase and one subject who phenoconverted to ALS FTD. So we weren't able to do real statistics because we only had 3 subjects, but we tried to use a descriptive and exploratory approach, plotting the results and trying to identify a visually significant difference between the asymptomatic, the prodromal, and the symptomatic subjects. So as I was saying, we had one female, age 67, who started to have symptoms of FTD with frontal impairment, clear frontal impairment, and then she had mostly spasticity of the lower limbs and some fasciculations, and now she's evolving to a real ALS. And then we had 3 other subjects that were in their 40s, so quite young subjects, who were considered as prodromal because from a cognitive point of view, they started to have some alterations at the different tests we do, even they didn't have a real diagnosis of DFT. So what did we see at cervical spinal cord MRI? Cross-sectionally, we were able to describe the presence of a gray matter atrophy, so a reduction of the gray matter cross-sectional area in the carriers compared to the non-carriers and also to the healthy controls made in the lower part of the spinal cord, at C4, C5, and C5, C6, which was confirmed at M36, and we observed that this atrophy seems to involve more levels over time. So at M36, we also observed an atrophy of C6, C7. In parallel, we confirmed the fact that FA is going down in the corticospinal tracts, but we didn't observe any modification in the dorsal column. So longitudinally, we confirmed that there is an evolution of the DTI alteration, but the most interesting for me is that we were able to describe a progressive decrease in the gray matter cross-sectional area. So we observe a gray matter atrophy, which involves several vertebral levels and seems to worsen over time. And when we consider the phenoconverter and the prodromal subjects, I mean, I don't know if it's clear, but what was interesting is that we observed that the phenoconverter has much lower gray matter cross-sectional area, especially at M36. There were no real difference in the white matter, and at DTI, the corticospinal tracts showed basically the same. The converter went down much more than prodromal subjects. We saw something at the dorsal columns level, but it was not so clear. So, of course, it's only 3 subjects and 1 phenoconverter, so not possible to come to any conclusion. But we found that it's nice to observe that the phenoconverters has a spinal cord MRI, which is very similar to the one we observe in sporadic ALS patients we've already described in other cohorts, which have a very clear gray matter atrophy and FA decrease. So, of course, we will need to have more subjects and possibly more phenoconverters. It's not easy to have them, but our hypothesis is that maybe gray matter atrophy could be a first sign of motor neuron degeneration, and we observe that it goes down when they approach phenoconversion. Will need to be confirmed. We know that there is white matter degeneration all over the history of the disease that starts very early, and it will be very interesting to have more phenoconverters to try to better describe this, what happens when they really start to develop the disease. So thank you for your attention, and thanks to all the collaborators to discuss.
Thank you very much. We have time for one question. We do 2.
Okay. Thank you. Thank you very much for the talk. I'm kind of curious. I know you did the upper level of the spinal cord because of the coil size, but your prodromal patient that you talked about had the lower limb manifestation. Would you predict that she would have also had the change in the gray matter area in the lumbar area? Is there a relationship between this and the limb?
That's a very good question. We really don't know because it's quite difficult to image the lower tract of the spinal cord. It's really a personal opinion, and I don't have data to support it, but I think it involves all the spinal cord, and maybe it starts at the upper level, so in the cervical part, but I'm not sure. So it's possible that someone who has lower limbs involvement could have a lumbar spinal cord atrophy.
Great talk, thank you. Does the gray matter atrophy continue throughout the disease, or is it overpowered by the change in the white matter?
So in ALS patients, symptomatic, we detect it very clearly and it goes down a bit. Then at some point they are so severe that it's not easy to detect further modification, but we know that especially at the beginning it goes down. So we don't know what happens in C9, at which time it starts and how it goes down, but we are trying to have more subjects to try to investigate it.
Thank you very much.